living longer, living healthier, living better than ever before. Welcome to Mountain Pacific's Healthy Living for Life, a weekly series that gives you the information, education, and expert insight you need to become an active participant in today's ever-changing healthcare climate. Here now is today's program host.
On average, 130 Americans die every day from an opioid overdose. How did we get here? And what's being done to battle this national crisis? Welcome to Healthy Living for Life, a show dedicated to helping you do just that. I'm your host, Beth Brown. Today, we talk about changes in opioid prescribing practices, alternatives to using opioids, and how these changes can affect you as a patient. Stay tuned. Welcome back. Before we talk about what's changing with opioid prescriptions, we want to make sure we understand what opioids are and why they can pose such serious risks. Joining us first this morning is someone you've certainly seen on our show, our own Alissa Sather. And thanks for being here this morning, Alissa.
Thank you, Beth.
So we've talked about opioids a lot on our show lately, but it's such an important topic. So let's start by just making sure we all understand again, what are opioids?
Sure. So opioids are a class of medications that include the illegal drug heroin. We've heard about that. These semi-synthetic medications, codeine, morphine, and then other prescription pain relievers. And obviously when they're used under the care of a healthcare professional for appropriate clinical reasons, they are effective, they can be safe, but obviously we want to make sure that folks don't misuse them. We often see opioids used for either treatment of pain, sometimes for products are used for the treatment of cough, and one of the side effects of opioids is constipation, so sometimes they're used in antidiarrheal preparations.
Okay. But they're mainly used for pain.
That's correct.
And so not all medications that are used for pain are opioids though, right? So can you talk about some of those medications that are prescription opioids used for pain?
Sure, that's a great topic. So the opioids have been around a long time, and they originate from the opium poppy. Mm-hmm. And those naturally occurring alkaloids would be those that are morphine and codeine. And then you get into the semi-synthetic opioids, which would be your hydrocodone, commonly known as Vicodin, oxycodone, commonly known as OxyContin, and then various other derivatives that are based off of that, hydromorphone, oxymorphone, and the like. And then we get into the synthetic type opioids that are basically man-made. And the common ones that we hear about are fentanyl patches, often used for the treatment of cancer pain, often used in pre-treatment for various procedures in hospitals, and then tramadol, and then lastly but not least, methadone, which is used for pain but also used to treat opioid abuse disorder.
So this is probably a little bit of a tough question, but the reason we're in this crisis right now is because opioids have been overprescribed. How did we get here, and why are so many Americans dying from opioids?
Yes, that's a great question. So, for about the last 20 years, there was a great big push for the providers in the community to treat what was being called the fifth vital sign, and that would be pain. The American Pain Society really felt like that was an undertreated situation, and that's difficult because pain is very very subjective. It's based different for different people. Those other vital signs, which we can measure, like pulse and blood pressure and heart rate and respirations, those are very easy to measure with instruments, and pain is not. So within provider practices, it was really a big push to try to make sure we evaluated pain at every single visit. And so that happened. In addition, there were new medications that came to be, oxycodone is one of those, OxyContin to be specific, where we really weren't sure of the addiction potential, the true addiction potential of those particular medications. So the use of those medications started to escalate. And then as that happened, we really did see kind of some increase in opioid use disorder, addiction, and even overdose deaths like you're talking about.
So why are opioids addictive?
Right, so that's a great question. Opioids have special properties. They bind to certain receptors in our brain and spinal cord, and in our brain they work in the reward center of the brain, and that is the one that makes us feel good. It also controls pain, and it's important to mention, and it's in specific individuals that might be at risk for addiction. In addition, there's the other side effects that aren't as significant, but can be, and that's drowsiness, dizziness, and confusion. And so we obviously want to make sure they're being used appropriately and in the appropriate situations.
Okay, and so if I'm prescribed an opioid, then what is it that I need to know?
Sure. So the most important thing really are that we want to make sure that you're not taking them any differently than as prescribed. We want to make sure that you talk to your doctor about the fact that there might be something else you can use to treat your pain. There are other medications that are effective and might be less risky for a certain individual. Those are really the biggies. You want to make sure that you have that conversation with your provider and that you dispose of any unused medication. That's a biggie, and keep them out of reach of children or others. That's important.
And so we've talked about disposal on the show before, but I think it's worth repeating. How do you make sure that you get rid of those drugs?
Yes, absolutely. So a couple things. There are prescription drug take-back locations that are located within pharmacies, can be accessed through the Department of Justice website and in sheriff's offices and whatnot throughout the state. The second component is if you don't have one of those in your area, you certainly can do that yourself. You put the medication in an undesirable substance like kitty litter or coffee grounds, put that in the garbage, strip the label off your prescription bottle and throw it in the trash. There are exceptions to that. Some medications are very dangerous. We don't want you touching, handling those, and you don't want those being thrown out in that specific manner. And those specific medications like fentanyl patches have to be disposed of through flushing down a toilet.
Okay, so we probably have time for just one more question. Lisa, you're a pharmacist. What role do you think pharmacists should be playing in helping to get America through this opioid crisis?
Yeah, that's a great question. Pharmacists are a valuable member of the healthcare team, as we've talked about before. And so pharmacists on the front line can help to educate patients when they receive an opioid prescription about the risks, about the side effects, about taking things longer or in greater amounts than is necessary. In addition, pharmacists are really valuable in looking for red flags as they're dispensing a prescription. Are there early unexplained refills? Is there consistent cash paying? Those might be a situation where there might need to be an evaluation recommended for potential opioid use disorder. Pharmacists also are helping to educate physicians in the community as we really look towards the new CDC recommended guidelines for prescribing. So those are just some of those areas.
Perfect. Thank you so much, as always, for being on the show and for such great information.
Thank you, Beth.
We need to take a break, but coming up next, the national opioid crisis has both doctors and patients looking for safer alternatives to pain relief and pain management. We'll take a look at some of those after this. Stay with us. We'll be back in 2 minutes. Welcome back. Prescription opioids can be an effective form of pain management, but there are other options that can be used with or instead of opioids. Dr. Alissa Abentroth, a general surgeon, joins us now, and thank you so much for being here this morning.
You're welcome.
So let's just start out with a general topic, and Lisa touched on this a little bit before the break, but what makes it so difficult to treat pain?
Well, pain is just such a complex symptom to treat. There's the physical aspect, there's the psychological aspect, and even an emotional aspect. So as you can imagine, if I operated on 10 people, same exact operation, everybody perceives pain differently, and so all 10 of those people could have a different level of pain. And treating acute pain is a lot different than treating chronic pain. Acute pain is just that. It's pain that we usually cause, and if treated correctly, it goes away. But if it's treated incorrectly, it can lead to chronic pain, which can be weeks, months, or even a lifelong problem for the patient. Very complicated to treat. Obviously, one size does not fit all. I wish there was just one recipe for every patient.
Would you say that opioids have definitely been our go-to when it comes to treating pain?
Yeah, 20 years ago when pain became the fifth vital sign, the main goal was how can we stop this pain in these patients? And so opioids at the time were thought to be the best method. We didn't know the addictive properties of opioids at the time. We were told as clinicians that using them in the clinical setting, they didn't have quite that addictive property. And we also didn't know just how poorly they work in the chronic pain population. Today we know obviously the risks of opioids, even the fatal consequences, and so we understand now that those risks definitely outweigh some of these potential benefits in opioids.
Okay, so how are we shifting now? Would you say opioids are still the go-to?
No, you know, there's been some really, because patient care, patient safety is our main concern, there's a great deal of national guidelines that recommend that we use non-opioid medications as well as even non-pharmaceutical methods to treat chronic pain. Even in the acute setting, there's amazing protocols that have been set up in treating acute pain without the use of opioids. So definitely a trend towards getting away from opioids and using other modalities.
Okay, so awesome. Let's talk about some of those other options. What are they?
I mean, one is just a very simple one, is just using non-opioid pain medications that we've all used for years. These include things like Tylenol, acetaminophen, ibuprofen, aspirin. Even some of the antidepressants have some pain-relieving symptoms for chronic pain patients. Other simple things that I use a lot in my practice would be creams, ointments, even lidoderm patches, which is basically a patch that you put right on the painful area to help numb it during those painful periods. Some clinicians are injecting the painful areas with anti-inflammatories or steroids. These are lasting weeks, even months, giving the patient some relief. There's also complementary medicine modalities. As I talked about before, there's a psychological and emotional aspect to pain, and so using things such as mindful meditation, yoga, stretching, cognitive behavioral therapy, these modalities have really worked well for these patients in this patient population. And then something that I loved and to be passionate about is just overall health. And so that includes diet, exercise, and weight loss. And as you can imagine, all three of those really work well for pain, especially when you're eliminating inflammatory foods in a patient's population. It really leads to less pain in those patients.
Well, that's great. It sounds like there are a lot of different options out there. Are there more high-tech ones that doctors are using now?
Yeah, there's some definitely really fascinating ones in the world of medicine. Some we know the science behind them, and some we don't really understand them, but we know that they're safe and we use them. We're using radio frequency ablation, so that's basically high-energy ablation or burning of the nerves that cause the pain pathway to stop that circuit from going over and over in that patient. We're using direct injections into the nerve. Again, these aren't long-standing. The patient would have to come back and repeat those injections. They're using electrical stimulation where they put a pad and it stimulates the painful area. Again, unsure of exactly how it works, but causes kind of a different sensation for the patient instead of pain. They're even putting pacemaker-like devices in the lower back that go directly into the spinal cord. It's called a spinal cord stimulator. It's kind of a last end resort, but it actually replaces the pain pathway with a more pleasant pathway for the patient, such as tingling. So when they feel pain, they push a button, and then the stimulator gives them a kind of a tingly sensation, so it avoids that pain pathway.
Amazing. Are there times when opioids are appropriate, either with those other options or by themselves?
You know, there still is a role. We use, obviously, opioid in the cancer patient population, end of life, palliative care, but also in the acute pain setting, we are using opioids. You know, we just want to remind our patients to use the lowest possible dose for the shortest amount of time, use them as prescribed. So there definitely is a role, but again, you're going to want to complement those with those other modalities that I talked about.
Okay, what about those patients who have been using opioids for a while? What's your advice for those folks?
You know, those patients are hard. You know, some of those patients don't want to give up their opioids, so that makes it a difficult patient population. But the ones that do, you also have to have really great communication with those patients and a great plan for those patients, because you don't want them to just to stop cold turkey. There's a lot of withdrawal symptoms that can be very devastating for the patient. So you want to have a plan where you're replacing those other medications or other lifestyle changes in with the tapering of those opioid medications. But really good communication with your provider and coming up with a plan that's literally going to be good for the both of you.
Good advice. Okay, one last question, I think. What advice would you give for patients in general to be engaged in their pain management or their pain care?
I really think, just like what I just touched about, is really letting your provider know your goals, what pain means to you and what your goals are with your lifestyle. And I think it's just that really nice balance of patients' expectations and how to alleviate the pain with the lowest dose of pain medication as possible, because on the practitioners or the prescriber side, we want to be as safe as possible. So effective for the patient, safe for the provider, to eliminate that pain.
Perfect. Thank you so much. That's all the time we have, but I appreciate you being here, Dr. Abentroth.
Thanks.
Coming up next, improving the way opioids are prescribed can help make sure patients get safer, more effective treatment for their pain. We'll take a look at new guidelines for opioid prescriptions and pain management. Don't go away. We'll be right back. Doctors and healthcare professionals who prescribe medications play a key role in the responsible and effective use of opioids. Joining us now to talk about how opioid prescribing practices are changing is State Medical Officer Dr. Greg Holzman. And thanks for being here this morning, Dr. Holzman.
Thank you.
So let's talk about how the opioid crisis has changed over the years.
Yeah, I think that's really important because it changes kind of the idea of how we prescribe. So as earlier folks have talked about, the prescription rates went up quite a bit 20 years ago, and we saw a huge increase of the overall prescriptions for a multitude of reasons as discussed prior. Now we're dealing with the consequences of that. And so when we start to look at appropriate prescribing, I think a lot of times we as providers, or even in looking at things as a population, break the groups up into different areas. We have what we call our legacy patients. Our legacy patients are people that might be on chronic opioids, did exactly what their provider told them to do. The doses were increased, and they continued to have pain, but they had, or things, and now they have an addiction or at least a strong tolerance to that high dose, and all of a sudden people are not prescribing it anymore. So how do you deal with those patients and deal with it humanely and help them wean down appropriately, or if it's a point where they have an addiction, get them into an addiction specialist that can work with it, understand all the aspects behind it. Then we have what we call the naive patients, that doesn't necessarily mean they haven't been on opioids before. They might have had it after a surgery or something. They might have tried some before, but they haven't used in the last, people use arbitrary time, 45 days, 90 days. Those are ones where the CDC guidelines are, I think, fantastic as far as kind of really thinking through how you would prescribe to them. So we don't continue to be in the problem that we're in. We don't have a whole new generation of people that are on high dose opioids and have high risk of overdose and other complications. So we're kind of looking at it in a twofold way.
Okay, and so now today, knowing that the crisis that we're in, are there different ways we should be looking at this opioid crisis?
Well, I think, there's, as a population, again, I really talk about three major things that people try to do, and that's just to make it more simplistic. But we want to prevent the problem. So that goes into appropriate opioid prescribing, education to the public, to providers, to kids as they're growing up, and just talking about opioids or drug use in general. We want to help those people that are addicted, and so those are treatments. And in the United States in general, our treatment system is cut-mealed, and it has its own issues, and it's definitely, we don't have enough providers. So how do we use this in the best way to get those people that need treatment to get care and compassionate care treatment? And the last thing I would say is naloxone. Naloxone is a drug that reverses an opioid overdose. And we're trying to get it out into the public a lot more, or first responders, police officers, others that might be around somebody who has an opioid use disorder or is using opioids, or even might be on high-dose opioids because of cancer pain or something of that sort. But when you give the naloxone, it reverses the effect of the opioids and can prevent the person from dying. You still need to get them to the hospital right away, because that will wear off and they'll go back in. Plus, when you give the naloxone, people go from the point that they were usually obtunded or sleeping to quick withdrawals. So they're in misery when they get the naloxone. It's not a comfortable feeling for them, but it can save lives.
What is a prescription drug monitoring program, and what role is that playing in the opioid prescribing?
So prescription drug monitoring is a very useful tool. It's different a little bit in each state, but I think almost all states have it. The only one that didn't have it was Missouri, and I think they're almost there. So, and many of them are talking across states, but we can look in those people that have access to it. You should be looking at your patients or reasons that you have to be there, but can see what a patient is taking as far as in the areas of opioids, and some of the other ones have more information of other drugs that you might be concerned about, some of the sedatives or other things. And that allows better patient care, because I think a provider can look in it and try to prevent drug-drug interactions or have real concerns about it. and think through that. It also allows a provider to see if somebody might be doctor shopping, as we say, going from different provider and actually have a substance use problem, and how do we deal with that, or if they're going to different pharmacies and stuff of that. So it's a wonderful tool in a lot of different levels and used in different ways in different states to help us give better care for the individual patient and for the population at whole.
Okay. I've heard you talk about disease of despair. What do you mean by that?
Yeah, and I think that's real important to do, because people talk about substance use disorder in general. And I'll still say, our number one problem in Montana and probably in most states is alcohol. Still is. Opioids has been a major problem, and it's shown the quickest deaths, where we've seen death rates go from, in 2010, 21,000 people died from opioids alone. By 2016, it was 42,000. The diseases of despair are, why are people getting into this? And we see that there's a lot of associations. We also in Montana and many of the mountain states have very high suicide rates. That could be very much associated with this. Opioid use disorder, alcoholism. People have despairs underlining maybe trauma that has happened, adverse childhood events, different things that they went to these drugs knowingly, or happened because a doc gave it to them, and then they've had this feeling of feeling a little bit better. To find their happiness. And so it's saying we need to look at those underlying issues and start to deal with the diseases of despair that might be causing these problems. And it's just moving the stream much further up. And that could be from childhood. There's a new thing called the good behavior game that's happening in a lot of schools that's teaching kids better resilience and dealing with it. It can talk about better connectivity within our communities. We all talk about, what has the electronic, revolution had, and there's been huge benefits to it. But the other questions are people getting the chance just to talk and be human together? And what things can we do in the communities to start addressing these issues, and not just think that person, that's a drug user. There's a really good person behind all that, and how do we get to them and help them with all their struggling?
Okay, great. Thank you so much. We're out of time, so we're going to stop there, but thanks so much for being here and for all that great information.
Thank you.
And I would like to again thank Dr. Abentroth and Lisa Sather for sharing their expertise with us this morning as well. And that's all the time we have for today. We hope you'll come back next week. Until then, stay fit, stay well, and stay healthy for life with Healthy Living for Life. Have a great week, everybody.
Healthy Living for Life is brought to you by Mountain Pacific Quality Health. We'd love to hear from you. If you have suggestions for future programs, visit our website at mpqhf.org or call us at 406-443-4020. You can also catch us on YouTube by visiting our website and clicking on the YouTube icon. Special thanks to Fire Tower Coffee House and Roasters. Production facilities provided by Video Express Productions.